Maybe. I got too much stuff open. There you go. Can you see it? Maybe. Anybody?
Definitely can see it.
Okay.
And I'm just gonna let you take it away, and then I'll jump in if you end up getting a call.
Okay. I'm on the wrong one, anyways. I think I'm on the wrong. Hold on. It's my first day. I don't want. How do you? Either way. Actually, here we'll do this, and then this. Oh my God! Hold on. Like, the whole slide just. 31 Berlin. What do you want? The other unit is going to be transporting one of the DSOF workers. DSOF has a child. All right, can you see that?
Yes, we can.
Perfect. So we're gonna talk about trauma overview. This is like just a basic overview of trauma and what we look for as providers. And we're there's various things that we're going to talk about. Trauma scoring, rapid transport and destination issues and transport mode. We're going to talk about the pathophysiology and the assessment and management of a trauma patient. Multi-systems trauma is recognition and management of the trauma, again, the pathophysiology of blast injuries and multi-system trauma. So I guess the age went up a little bit, but according to I can't remember wherever I found this statistic from, but anybody below the age of about 40-ish die from accident prone or trauma. Anybody like usually over like I think 40 to 60 is cardiac, and anything above 60 is usually cancer. So whenever we get called to a younger person, we usually are thinking trauma for an overview. And so what trauma is like a physical force, be it a sharp object or a blunt object that's struck the body at with some type of force to leave injuries. So like depending on the mechanism of injury, we have to be aware of what sort of injuries could be occurring. So if it's like a motor vehicle accident, we're going to be like checking and depending on how hard they hit, if there's any scarring on the windshield, we're going to be thinking of any brain injuries. Traumatic injuries occurs when body tissues are exposed to energy levels. The mechanism of injury is the way the traumatic injuries occur. So like again, for somebody who gets hit with a baseball bat, it's blunt trauma. But if somebody gets cut with a knife or a bullet, gets shot with a bullet or whatever, that's a penetrating trauma. And like depending on the velocity of the bullet, it like could cause trauma around the wound as well. So there's three types of energy, or that we're look at. The three types are potential, kinetic, and energy at work. So, and it's something that I don't know. They kind of keep pointing out in the chapter, like energy cannot be created nor destroyed. It can only be converted or transformed. So like something that's in motion, it's gonna be in motion. Newton's second law, unless it's like acted upon by equal and resistant force. Work is force acting over a distance, and forces that bend, pull, or compresses tissues beyond their inherent limits result in the work that causes injury. So I really hard to describe it like a workforce, but like I guess it's like what sort of energies over the period of time or area of time. So that's something like a vehicle is traveling at 65 miles per hour. How much work is it doing, and how much work is it going to get to stop that vehicle? And also like how much, if you're like the example they use in the book is like bending a rod, like how much force and like over time will it take to bend that piece of metal rod, and at which point. So kinetic energy is the energy of a moving object. I looked up Khan, like if you do search viz on the Khan Academy, like they do a pretty good job of talking about energies. The three kinds they're talking about here. So kinetic energy is basically an object that's in motion, how much energy, potential energy there is. So the equation to figure out the joules of energy in something is like half its mass times the velocity squared. And they gave the example of like two things of cheese, like one is twice as big as the other one, and they showed how like the velocity or the speed of the cheese is more important or has more potential of energy than like the larger piece. So it's not mass, it's the issue, it's the speed of the object. So if a car hits somebody like at 5 miles an hour, it's not going to do much damage to that person. But if it's going 65 miles an hour, it's going to do a lot of damage in the person inside. And then depending on like this stopping period of, so potential energy is like the book. I think they showed a bow and arrow in the book of like being drawn back. Like that's energy stored in the shaft of the bow. It's not there, like there's no energy created, but if that person lets go of the string, like the energy is going to be transferred to the arrow, and which then that will be the kinetic energy in that arrow. So like, and something that we need to look at for like potential energy is like people falling from height. Like what height are they falling from? If they're tripped and fell on a ground level, like a young person, they're not going to be as badly hurt as like if they fell from like 20 feet. Then we're going to be more worry of how much traumatic injuries and to where, like if they jumped from a tree and down, we're going to like looking at the hips, because that's all that energy is going to be transferred into the hips, and it's not going to withstand it. Any questions on the types of energy? No.
No,
The Khan
not yet.
Academy, not yet. The Khan Academy really had good videos, and they're pretty short. If you need. So, mechanism imagery profiles. So the different MOIs produce many types of different injuries, obviously. Like, so somebody getting hit in the chest with a baseball bat is going to be different injuries for somebody who's going to get hit in the legs, or if somebody's in a car accident, or if somebody falls, or like if somebody's burnt, which is a type of trauma. Like, you just need to be thinking about what type of injuries can be could be involved with the accident. So like somebody who's involved in a slow machine accident, if they hit their head, there's a chance for a brain bleed. Or like I've seen more femur fractures on slow machine accidents than probably anything else. So significant injuries are injuries more than one body system, falls from height. So like again, I think for criteria for automatic dispatch for Darton was like 20 feet. That was in Colebrook. We don't automatically dispatch Dart or main flight up here. But so like these are all significant traumas, which would the person needs to be into a trauma center. So they would automatically dispatch Dart versus like any of these. If this came in as dispatch in this way, and then we could always cancel them. So like falls from anything greater than height, 20 feet of height. But see, like also like with the potential energy, like if they fell on concrete versus if they fell on lawn or like leaves or something. And again, motor vehicle crashes or motorcycle crashes, like what did they hit? If they hit a moose or did they hit a telephone pole? Car versus pedestrian and gunshot wounds, where did they get shot? And like the caliber is always a good thing to know. And stabbings, like where did, again, that would be penetrating. So what injuries, like if somebody got stabbed in the chest rather than the abdomen or just cut. So any questions on that? No. Blunt versus penetrating trauma. So blunt is like, yeah, like when the skin's not cut or penetrated, um, which can cause a lot of injuries in its own. And there, you can't. Sometimes it's hard to tell what is injured, especially if there's a thoracic cavity or abdominal cavity, because there's referred pain and there's so much going on there. So you can't see it, so you're just kind of treating for the best you can with what you see. But that's also why it's important to get trauma naked. This, like over the summer, we had like a couple of people involved in an ATV accident, and they both spoke a foreign language, and it was really difficult. But they said like, "Oh, there's no pain, no pain." And we got to the ER, and then the nurse lifted up one of the patient's shirt, and then like one had a huge bruise on his abdomen. So I kind of miss that. But penetrating trauma is like when it's piercing the skin or like there's bleeding involved, and depending on where it is. So blunt traumas results from an object making contact with the body. Motor vehicle crashes and falls are the most common MOIs. And so like the biggest indicator for us if somebody's in shock or how they're doing is skin discoloration and pain. Like where is their pain? And always be like if they have pain like in one area, like their leg, if they have a broken leg, like that doesn't mean that there's not injury somewhere else or they're bleeding somewhere else, or if they're bleeding internally, they don't even know it. So this is a head-on collision with a small car versus looks like a light pole. And they're saying like the crash consists of 3 collisions. So when the vehicle hits the object, that would be considered one collision. And then the body will hit, let's say, the steering wheel or the airbag, or if they're seatbelted, that is another collision. And then the internal organs or the brain will like, get rattled around inside. And so that would be the third collision. So like again, like assessing the vehicle, you can determine the mechanism of injury. There's some, I can't tell if there's starring on that or if it's just a broken windshield now. But what would you think some of the injuries would be for this vehicle or the driver?
Chest, possibly a head injury, chest and head.
Yeah, definitely a chest because the airbag would either go into the chest.
I'm thinking lower extremities.
Yep. Yeah, their knees. Like if they hit the dashboard with their knees.
Yep, and hitting the steering wheel, like,
hitting the steering wheel. And they're saying like now, you know how people like to put their feet up on the dashboard or legs.
Yeah.
Yeah, that's a big no-no because the airbags will destroy people's lower extremities. So I guess this person got T-boned by the looks of it. What injuries would you think would be sustained for this one? For this patient?
Well, the seat is slid. The seat is slid all the way up underneath the dash, so I would definitely think feet,
Yeah.
chest. Oh man, everything pretty much.
It looks like there was like front impact and side impact. So like, but yeah, this person probably got flown.
Well, they ripped the side. They ripped the doors off, and you can see the middle post.
Yeah. Again, yeah. So if they're wearing a seatbelt, there's probably a lot of injuries, lower extremity injuries, thoracic injuries, brain injuries, head injuries. So this would have probably been flown out. So this is they're talking about contra coup and contra coup. Like this is when the internal organs gets moved around a lot. Because like a vehicle going 65 miles per hour, your body is still going 65, and even though if the car stops, that energy is going to be transferred into your body, into your organs. So he was not wearing a seatbelt, this person, and he hit his windshield. So the coup part is when his brain like moved forward, because like we have room in our head that's filled with spinal fluid. So like his brain like sloshed ahead and hit the interior part of his head, and then like on the way back, he went back and hit the backside of his head. So it's a coup and then contra coup, the backside. And so that's how people get brain damage or concussions. Even in the NFL, that's kind of what's happening. And with older people, like their brains shrink, so there's a lot of vasculature in there that as well it can start bleeding, and they need to be transported, especially if they're on blood thinners like Coumadin, because they just don't stop bleeding, and the brain does not like blood that's not contained. Any questions, coup on contra coup?
No, Morgan, I just looked up the meaning of it because I wanted to see if it was just to the brain, but the wording means it's French for blow and counter blow. So it can happen to other parts of the body too. It just happens a lot with the brain, correct? I
Right.
mean, you have a hard surface in the front and the back.
Yeah. Yeah. I'm sure it could. It's mostly known for like the brain though.
Right. Yeah.
And the brain's like kind of sloshed around in there. So again, this should have been up with the over. So significant MOIs include the findings of a death of an occupant in the vehicle. So if there's like two people in a car crash or more, and there's one that's fatal, then there three others are walking around and they're fine, I would have a very high suspicion that something's about to go down with one of them, and they should probably be into a trauma center. Severe deformity or vehicle or intrusion of the vehicles. So that means like if their motor is into the passenger compartment, mostly. But if like there's significant side damage as well, that's a good severe damage from the rear, crashes and rotations involved. So if like they start rolling or if they get spun in the vehicle, in ejections, like if they're not wearing their seatbelt and they get thrown, that's hugely and significant MOI. So frontal crashes, evaluate the supplement restraint system. So we always, anytime I go to any vehicle accident, where you're wearing your seatbelt. In Maine, it's illegal. New Hampshire is live free or die. So if you're above 18, not everybody wears them. So then, if what airbags were deployed, if there were side airbags, front airbags, roof airbags, because I've seen like some people that like you thought they were not going to be making it very long, but vehicles are made for that too. They're like break away to like really get rid of that energy, like absorb it into the vehicle more than into the people. But you would come up onto an accident scene and look like somebody who's not going to be walking out, and everybody would be fine. So like airbags, like seat belts. Airbags. So yeah, and then if the airbags go off, like there could be other injuries involved, like broken noses, and sometimes like broken arms, hands. One guy had a broken sternum from an airbag, as well. So just because airbags go off doesn't mean like people don't get hurt still. And then children shorter than 4'9" should ride in the back seats because of airbag deployment, and they were kind of coming up and over the seat belts. And if an airbag does, just be careful if you're like on an accident scene, like about if something doesn't go off, doesn't mean it won't while you're in front of it. Like, so just make sure like the bumpers are secured because they can always shoot off, and the airbags can always just randomly shoot off as well with like your head right there. So this picture shows like an improperly placed seatbelt. Do you see how like it comes down over his shoulder? This was the driver, right? Yeah. So he was a driver, and then he did not have his seatbelt over his like legs or his hips, like had it over his belly, and so that's like this. Do you see my mouse, or do I have to pull up the?
Yes. Yeah, we can see your mouse.
Like the spleen would
And
be
the
right.
reddening there. Yep.
Yeah. The spleen, the liver, I think. So there's a lot of abdominal issues that could be going on right there. And there's a little, I don't know if that there's definitely bruising, like up in his upper right quadrant. So yeah. So even if they are wearing their seatbelt, make sure that it's properly used. Look for contact points between the patient and the vehicle as they perform a simple, quick evaluation of the interior vehicle. So like whenever everybody gets tunnel vision on crashes, like ATV, motor vehicle crashes, like I always want to run to the patient, which is good. Like they need to make sure they're safe and everybody's safe. But I like to walk around the vehicle just to get an idea of what's going on for the injuries, what could be, how like the impact, and then the ER provider is going to want to know what's going on as well. Even today, like I'll take pictures, and so they can see in the ER. So a rear end crash, and a lot of those cause whiplash. So that's when you hyperextend or hypoextend your head and neck, and kind of pulls your ligaments in your neck. The body's propelled forward. So you're just gonna think if you're stopped and somebody hits you, your body's gonna go forward and your head's gonna go forward, and then as you stop, it's gonna flop back, and that's when you can also get a coup and contra coup injury. Side impact. Oh, this is the T-bone. Maybe the other one wasn't before, but anyways, so the T-bone's like, or lateral crash, we call it, is like you get hit on the side of the vehicle. And this, this is probably one of the good parts of being seatbelted, because your body is trapped and somebody's like a vehicle is like pushing you in, and this can do a lot of damage. Like I got T-boned once, and I got pushed on the other side of the vehicle. But your head can do like a side to side whiplash instead of front and forward, front and back. But that's a lot of people like who run red lights. That can happen. A vehicle struck above the side is usually struck above its center of gravity, begins rocking away from the side impact, and results in passengers sustaining whiplash. So like the lateral, the side to side. Again, what injuries? Here we'll back that up. What injuries do you think would happen with a T-bone or lateral impact?
Chest,
Yep, chest,
pelvis,
probably some pelvis.
and I bet some of your solid organs might take a hit.
Yeah, the depending abdomen, probably
Yeah.
the neck.
I mean, and we've already talked about the lateral whiplash, so
Yeah,
that's a given.
yeah. So fractures, lower extremities, pelvis, ribs,
Hmm.
organ damage from the third collisions, and then the chest and abdomen, just because of the place of impact. So rollover crashes, they'll usually occur with a higher vehicles with higher center of gravity. And if they're not restrained, people usually get thrown out and then are ejected and are fatal most of the time. Or partial ejection when they come through the windshield and it still rolls them. And again, I guess spins are a little bit like rollovers. If you're not seatbelted in, you're just going to be a missile in a vehicle and just going to get thrown around. Any questions on crashes? No,
Not yet.
not yet. So injuries are graphic and apparent for pedestrians. Knock on wood. I don't think I've ever been to one. I don't really want to be in one. But depending on the age of the patient, and how tall and big they are, depends on the injuries involved. So you need to determine the speed of the vehicle. So because that causes more injuries. The bigger than the faster. If the patient was thrown in the air, if he was thrown on the tar grass, or if the patient was struck, or if he went underneath the vehicle,
Morgan, how would
Yes.
we determine the speed of the vehicle?
Traction marks. Ask.
Like
Say what
ask PD. PDs can figure it out.
No, ask if the driver, if he can answer.
I mean, how accurate do you think they're going to be? They're going to say they were going slower than what they were doing.
Probably. Yeah, you can just ask the PD, and then, or if there's any skid marks.
Okay. So in a
Like-
perfect world, we'd know the speed, but in reality, that's going to be a pretty difficult without having tons and tons of experience of this type of this type of accident.
Right. They have special people for that. The police, the traffic,
Special people.
the traffic people. I wouldn't know how fast somebody was going by looking
Right.
at it.
When I read it in the book, I'm like, I don't know how I
You
would
can
figure that
guesstimate.
out.
You can guesstimate, then ask, and then when you document, driver stated that he was going 55 miles an hour or whatever.
Could you also just kind of document if you can't get that out of the driver, like what the speed zone is, and say
Yeah.
the speed zone for that area is such and such?
Right. Yeah. It's another way. So yeah, if the patient was struck and then like thrown through the air, he'd be a lot different injuries than if somebody was pulled under the vehicle. Because they'll probably get burns and some crush injuries, depending. Evaluate the vehicle that was struck for damage, because you're gonna be able to see where the patient hit, and like you can, I guess, like if somebody got run over the front of the vehicle, you're gonna see if they hit the bumper, they're gonna have more significant injuries on the tibia, and then working their way up where they fell, like probably ribs.
I guess I don't understand why we would be evaluating the vehicle. I mean, I understand, but if we're working on a patient and
Yeah.
they've got life-sustaining injuries here, I don't understand how you would work that into your assessment.
Because your teammates, like I said before, there's gonna be, I don't know how many people there on a scene, and they're all gonna go for the patient, and so I want an overview of a bigger overview.
Okay, so somebody's going to evaluate the vehicle.
Yeah, it doesn't have to be you. Somebody should.
It can also be pretty quick too, right, Morgan? I mean,
Yeah.
you're already going up to the vehicle for the patient anyway, so you can do that whole side. I mean, you're
Oh my
gonna
God, you just,
front
I can't hear you.
or roll over or whatever.
Can you say that again? I missed most of. Sorry.
So I think what it is it's a pretty quick type of investigation. You're not walking, you're not taking 5 minutes, because we want to probably get that patient out of there within 10 minutes.
Right.
But you see a lot of it when you come up to an accident. And like I said, you're going up to the patient anyway, so you already see that portion of the car, the damage to the dashboard. Did the roof come down and hit him in the head?
Right.
A lot of those things are pretty quick observations, I would think.
No, but
Yeah.
this is a pedestrian, and chances
Oh,
are
I'm sorry.
they're gonna be pushed away. I'm just like, if you're coming up to this and yeah, PD's there and you've got yourself and your paramedic with you,
Yeah.
I mean, in remote areas, it's just gonna be two people at first. So I'm just wondering, it's saying evaluate the vehicle. Well, that is
Take a quick
probably,
second. You're right. I would be on the patient and make sure there was no injuries that need to be taken care of.
yeah. I mean, that would just be the last thing that I would be doing. And I would probably look if ALS showed up and took the patient and I'm left there with my ambulance, well, then I would definitely look at the vehicle. But
Right.
I'm trying to figure out where you would put that in your actual assessment and treatment, because it is trauma.
Yeah.
And they could throw this at us at a test, because isn't that what we get tested on, is trauma?
You will, but you won't.
Yeah.
You won't do that.
Okay.
This won't show up in any. I mean, you're gonna. I can't say it won't show up in a test, but it won't be like your patient always comes first.
Okay.
At the
So
end of
if
the,
we're being tested and this is a scenario, it's going to be the patient. I don't need to say, I'm going to evaluate the vehicle that struck the patient for structural damage.
right.
Okay. Thank you.
Zach or Kevin, I don't know if you want to have anything else if you're there. Maybe not. Okay. Yeah.
Sorry, Morgan, what did you say?
Tina asked, like, you can ask him again, Tina.
Well, so our test is going to be on trauma. And if I'm given the scenario of a pedestrian being hit by a car, I just don't know where I would say in there that I'm going to evaluate the vehicle that struck the patient for structural damage. I mean, if there's two of us on scene, we're going to the patient. If after we evaluate that the scene is safe and we BSI, we're going to the patient. I just don't understand the evaluation of the vehicle. Like, am I going to be required to fit that in to the test? Because certainly in real life, that would not be before I would go to the patient.
It depends. I would verbalize that, because I will tell you, in my experience, especially with an EMT, I would have my EMT partner walk over to the car and visualize the inside compartment and the damage while I'm doing my primary assessment on the patient. And then I use you as my eyes at that point and say, what did the car look like? Was the steering wheel built? Was the windshield scarred? Is there damage into the patient compartment? If I'm by myself, you're right. Patient care comes first.
But
However,
this is car
Yeah.
versus pedestrian.
okay. I mean,
So
I
the
still would
pedestrian's
look at,
probably thrown.
yeah, I still would split up and have my partner just assess the vehicle for any damage. I mean,
Okay.
it's obviously a person, so they got struck by a car. So if you see a lot of damage on the car, that person's going to be in really bad shape. If you don't see anything, it's a very quick glance. And it's kind of like as you're walking by the car, you stop, you look, and then you keep walking to the patient. So it's not
Okay.
like you're going to get down and, really, really inspect it, but it's more of a mental note.
Okay. So we should say, if this is a scenario that we're given after, scene safety BSI, we're approaching the patient, we are evaluating the vehicle for structural damage.
I would consider this part of your scene size up. So yes, you're
Okay.
checking for safety issues, but I would also say that. So if I, for example, I would say BSI scene safe. I assess my scene. How many patients? Oh, you've got one. I noticed this was a vehicle. What kind of damage is in the vehicle as I'm walking up to my patient? And that's how I would verbalize it.
Thank you.
You're welcome.
Did that answer your question, Tina?
It sure does.
All right,
Thank you.
So car versus bicycle. Evaluate you like you would for a car versus pedestrian collision. I mean, check for the damage on the vehicle. Evaluate the damage to the position of the bicycle. I mean, if you're going to be able to tell how much force was used if, like, the bike is really stove up. If the patient was wearing a helmet, inspect the damage, for any damage as well. Like, that's for any helmet. Like, usually if we go for an ATV, motorcycle, whatever, if there's a helmet involved, we bring it with us, because it can show a lot of what was going on. Presume that the patient has a spinal cord injury. So yeah, you're for states who do backboarding, they're gonna have to be backboarded, or if they don't, they are gonna have to have the motion restriction put on. Because just getting bounced around, especially the head. So car versus motorcycle protection. This is from the helmet. Leather for road rash and boots. And if they're not wearing any leather, just make sure being cognizant of road rash and where it is, like how the person landed. And again, this is probably going to be spinal injury as well. So yeah, when assessing the scene, look for the damage to the motorcycle, whatever the motorcycle hit, any just skid marks, and extent and damage to the location of the helmet. In the helmet, because that's going to show where, if there's any brain injury, where it's going to be in the brain as well. A head-on crash, motorcycle strikes another object and stops the forward motion. So he's probably going to fly over, depending on how fast he's going, and sustain injuries that way. And angular crashes when they don't do a head-on, like, I guess, a glancing blow. And if they get hit, their lower extremities or not. Riders of high-end speed will, fly off their bicycle, and they could get hit, if they fly off the motorcycle and hit a vehicle. Controlled crashes, I guess, the techniques used to separate the rider from the body. I guess that's when they lay the bike down, and the bike keeps
Yeah,
going.
we see a lot of those at the track. And,
Oh, do you?
yeah, what they do is they go down on the left side, and they come detached from the bike, and they just slide because they're wearing that suit. So I see it a lot happen.
There's not many injuries with that, or no?
No, usually they just pop up on their 2 feet and walk it off. Yeah.
Yeah. Thank you. So falls. Injury potential depends on the height of the patient fell. Anything greater than like 20 feet or 2 stories is considered significant. And depending on where they land, if they land head first, that's very significant. If they land on their legs or whatever, like that'll, again, the energy will get transported up into their hips and they'll have like hip injuries, like, and if they land on their bellies or their backs, they could do a lot of thoracic abdominal injuries or kidney, like mess up their kidneys. So like somebody who fell, like this is I don't know, 10 feet or so, and she's gonna land on the balls of her feet, and all that energy is gonna go right up into her hips, and then up into her spine, and then come out there somewhere. So we got to tuck and roll.
I'm good at falling.
Oh, me too.
I can tuck and roll.
Oh, I have a funny story about that, but for another time when I'm not professional. Take the falling, the height of the fall, the surface, like if they're fall on a grass or dirt, or rather than concrete, like concrete's not forgiving. Or if it's stony, then the part of the body that hit first, which you can usually tell, somebody falls on their shoulder or their neck, they're going to have significant shoulder injury. If they fall on their head, they're going to have significant head injury. So, any questions about blunt trauma? No. Or car crashes or anything like that? This is interesting. So, penetrating trauma. This is the second leading cause of trauma death after blunt trauma. Because there's only 2 types of trauma, I guess. Accidentally be impaled or intentionally by a knife, ice pick, or other weapon. What injuries do you think that would happen with this? It looks like a knife to the left thoracic area.
They would have a collapsed lung.
Collapsed lung. Yeah. Cardiac tamponade, maybe. Bleeding. Could be nothing. Depends on if you take a deep breath, you could have liver issues. With low energy, is this like sharp injuries? So they're just cutting or lacerations. Knives can be deliberately moved around, so like the twisting motion to get more of their organs. Just like somebody really pissed you off. Just, path of the projectile may not be easy to predict. So bullet wounds. So it's good to see like where an entrance wound and an exit wound is, because sometimes like depending on the projectile and type of bullet, they just could go in and just start ricocheting and not even come out, and like make up a lot of damage. And if they're hollow points or whatever, they'll just mushroom and really make a mess. Cavitation results from rapid changes in tissues and fluid pressure. So I guess they're talking about like anytime there's this injury, there's going to be fluid like either plasma or whatever, third spacing, and so you're just gonna have swelling, like a cardiac tamponade. So it's gonna be cause results to internal, like it's gonna push the heart, or depending on where the bleeding is or whatever injury where it is, it's gonna be like cause issues. Like the heart won't be able to pump if there's like swelling involved. Relation between the distance of severity of injuries depending on the type of weapon involved. Air resistance slows the like a projectile down a bullet, and like a 22 is not going to do that much damage. Maybe, hopefully, depending on where it hits. Like I'm not into guns or ballistics, so but like a 30-06, which is bigger, more velocity, and depending on where you're going to hit from, like how far away you are, it's going to do a lot more damage. And the bigger the caliber, the bigger the hole. So it's good to hopefully figure out what kind of ammunition was used. And no, I would not definitely give up patient safety or yourself safety for finding what type of ammunition it is. But if you have it, it's available, I would just take it. Or let the police officers handle that part. So here's a chart describing like the different areas of injury. So like for a blunt penetrating trauma to the neck, like what signs and symptoms are showing what it should be for suspicion, index of suspicion. Do you guys want me to go over that, or you've already read it? You read it?
Read it.
Okay. You're good. So blast injuries, most common in military conflicts, seen in mines, shipyards, chemical plants, terrorist attacks. Like the Boston bombing.
Mill blew up a couple years ago.
What's that?
The J Mill blew up a couple years ago. I don't know if anybody ever heard from that. The J Mill.
I did not know or hear. When was that?
Probably 2 or 3 years ago. There's a really cool video of it. I mean, it's not cool, but there's a guy in a truck and they're all waiting in line to get in. And
I did hear about that.
Yeah.
I did hear about that.
Yeah. I don't think too many people got hurt, but that type of thing happens.
Yeah. Well, up in Colbrook, like, the mag factory, they produce black powder. It was not good. So and again, there's like blast radius and how many. It kind of like a motor vehicle accident. Like you're gonna get hit with a concussion from the blast, and then your body is gonna get thrown, and then your internal organs are gonna get rocked around inside your body as well. And then so you also have debris that's gonna be getting shot at you as well, or it's depending what type of blast if they put anything in it. The primary blast injuries due entirely of the blast itself, damage to the body by the pressure wave. The secondary blast injuries, damage to the body by flying debris, and the victim is hurled by the force of the explosion. So the tertiary blast injuries. Quaternary blast injuries, burns from hot gases fired, respiratory from inhalants, and crush injuries from like if buildings or whatever fell on people. And most patients have a combination of 4 types of injuries, like varying degrees, depending on the injury or the blast type. So the middle ear, is most susceptible. Like that's where you get the ringing, dizziness, and stuff like that. Lungs, which is a hollow organ, and some of the gastrointestinal tract, which also is like some of the hollow organs. So because of that pressure wave. Pulmonary blast injuries result from short-range exposure to the detonation. Arterial air embolism can produce disturbance of vision, change in behavior, state of consciousness, and variety of other neurological signs. Like I guess somebody who's like they're having a concussion. Solid organs are relatively protected. They don't get affected much. Neurological injuries are most common causes of death. Traumatic amputations are common, like legs, arms, stuff like that. Any questions on blast injuries? None. I would not see what was the explosive. I would just kind of get the patient and get out of there as well. But I would tell the ER what happened if you do have patients. And usually they're going to need surgery. Involves more than multi-system, yes. Involves more than one body system. Like that's kind of like a skeletal system or abdominal issues. So alert medical control and transport to like. So yeah, as soon as like if you have any of this, like call a quote unquote trauma alert so they can get their radiologist, or if they have surgeons on call, so they can start fixing these people. Or if you can find out if DART or MED flights flying and to get them in there. Multi-systems trauma patients have like a higher level of morbidity and mortality, just because of the extent of their injuries. So your main priorities. What's the main priorities on a scene?
Safety.
Fire safety.
What's that?
Safety
safety.
for us.
Yep. Safety for you, safety for your partner, and safety for your patient and your crew. A deed for additional personnel or like ALS or DART or main med. And again, evaluate the mechanism of injury. Identify and manage life threats. Then focus on the patient care. So hemorrhage, we're starting with hemorrhage because if they don't have blood, they don't have an inpatient. So then airway, is it clear? There dentures where they're eating, voluntary, like in breathe for them if you have to. Treat for shock, and always do some sort of spinal immobilization. And if you think they're okay, then you can clear their spine. In New Hampshire, I don't know what Maine's protocol is, but back when I started back in like when I had to walk uphill both ways in that was actually in 2004. We collared and backboarded any type of trauma. It was backboarded. And then transport to the immediate facility. Like if there's multiple facilities around, the closest appropriate one. Definitive care requires surgical intervention. On-scene time should be limited to 10 minutes or less. So, like, if I would question that with if you has to extricate the patient at all, or there's just different issues that go along with care. So that's like not a hard number. Consider ALS or air medical for ALS, like pain control or whatever else we could do. If we need the DART or chest, IVs. When a patient has experienced a significant MOI and critical condition, rapidly perform a physical examination. Like you do that. If anything bleeding that I need to, or broken, like that quick head to toe. When a patient has experienced a non-significant MOI, use the chief complaint. So if they're like kind of alert and oriented, you can just focus on like my arm's broken, and then you can just deal with that. Injuries to head, disability, and unseen injury to the brain may occur. Bleeding or swelling in the side of the skull is life-threatening. So we need to be doing, if they're alert oriented, we need to keep checking their neurological exams if there's any injuries to the head. Some patients don't have obvious signs or symptoms. Oh, there's a kitty. So just like every time you do an exam, you can like, do you know where you are? Do you know what you were doing? Usually, like a lot of head injuries that I've been to, they're like, we'll start asking the same questions over and over and over again. Like, what am I doing? Where are we going? What happened? What am I doing? Where are we going? What happened? Over and over again. So you know there's something going on.
Morgan, what neurological examinations are we gonna frequently do? Like, is it the
Do the other,
Glasgow,
yeah, absolutely.
the Glasgow scale,
Yeah, like just
and
keep
then the revised trauma?
yes. Well, yeah. Like anything you like, it's just part of your assessment. It's like an ongoing fluid thing, and you just keep, once you stop, like work your way down and start all over again. Just keep talking to them, and once, do you know where you are? Do you know what happened? Do you know what town you were in? What are we doing right now?
Okay,
And
so
then,
the alert and oriented, that whole, like, just keep repeating those.
yep, and then have them like grab your
Yeah, the fingers.
fingers and
Okay.
squeeze, and then they talk.
Yep.
If they can talk to you, then like they can follow directions, and you can
Okay.
learn about speech, and if there's any like amnesia, like that'll pop up real quick. Or if they become agitated, that's another brain injury thing as well, like nausea, vomiting, anything like that. Checking the pupils,
Okay.
have them smile for you. Tell them it's a sunny day in Boston. I think we missed this one. Neck and throat, area of serious deadly injuries. Always problems. Airway problems may result in trauma. Some, if they're like bleeding or whatever, especially if there's like trauma around the airway, like you want to control bleeding so you don't aspirate or choke. Swelling prevents blood to the brain, so make sure that there's nothing you can do. Just transport, keep them warm. And like if there's any open wounds in the neck, cover it up, because you don't want an air embolism. Penetrating injury may result in air embolism. But if there's like ever a knife involved or whatever, there's something, don't pull it out unless like it's directly involved in the airway. Just kind of stabilize it as best you can. Crushing injury may cause cartilage, upper airway, and larynx to fracture. And again, that's an airway problem. So just ventilate as best as you can. Chest injuries to the chest. So they contain vital organs like the heart and large blood vessels and lungs. So life-threatening injuries may, like broken ribs, pneumothoraxes, cardiac contusions, pulmonary contusions. Like if there's a high speed, there's the aorta. It's like held up by oh my god, a ligament. And so if like there's a good enough speed, that aorta will tear and they'll just bleed out right there. A penetrating or perfusion of the integrated chest walls, called an open chest. So again, you kind of treat that with a occlusive dressing, which all are state mandatory for to have them on there, but you kind of put like a three-way, like a pad over it or a wrapper, so air can't get in. It's kind of like a valve, a one-way valve. So like when they breathe in, that will close, but when they breathe back out, that will push the air out. In theory, so it doesn't get any worse, but it might make it better. So check for decap BTLS, check for lung sounds and rise, like symmetrical rise and fall. I've never seen a flailed chest. Did they talk about a flailed chest at all, or we're gonna probably get into detail with the thoracic injuries?
I was gonna ask you if you'd ever seen one. I saw one online one time. That's where a bunch of ribs are broken, right? And their chest is
Yeah.
like coming out really far.
Right. So there's like 3 or 4 ribs, like consecutive, like in broken 2 or more places. So it looks, there's a paradoxal motion. So like when they breathe in, the ribs will go down, and when they breathe out, the ribs will pop out. And that's when we use the sandbags that Kevin was talking about. But we don't do that anymore.
It's super obvious. I saw it twice last year from snow machines and handlebars. The people were going really fast and they would hit the handlebars when they wrecked, and it would fracture a bunch of ribs. They're going to be in a lot of pain, and it'll be super obvious that that's what's going on.
Right. I don't think it was last year, but the year before, somebody was in an ATV accident, and he was saying he had chest pain. And I went around and looked at his back, and I don't have my camera on. I don't have a camera, but there was like probably a 6-inch laceration that went into his intercostal muscle, and you can see inside his thoracic cavity. And like, it was pretty rad. I wish I had taken a picture, but I didn't. But
You're sick.
yeah, that was pretty.
Love it.
Like, he was fine. So the abdomen contains vital organs as well, like the spleen, liver, pancreas, kidneys. Like getting hit in the kidneys is ouch. So those are the solid organs. Hollow organs include stomach, large and small intestines in the bladder. So yeah, the solid organs may tear, lacerate, fracture, like the spleen. We get a lot of spleen injuries, especially with ATVs. Hollow organs may rupture and leak, or liver will be a good one too. That will get messed up. So you got to make sure that there's no bleeding in the abdomen. Usually, like that's when we press on the belly, and if there's bleeding there, it's pretty firm. You can tell, or it could be red, or just because of the mechanism of injury. You just got to make sure. So we want to keep our scene time to a minimal. I think where was it, Pennsylvania? They found out like people who were being shot, like cops are always up first on scene, so they like throw the victims in the crews and just bring them to the ER, and they had a better chance of survival than calling EMS, because I'm going to practice my full extent, so I'm probably going to be on the scene a little bit longer, but like they had definitive care in the end. So yeah, keep your scene time for as short as possible, but you need to make sure that you do the best you can with what you have. Critical injured patients, dangerous MOI, decreased level of consciousness, and then like you're gonna be altered. They're gonna be like they can be alert, but then not oriented or verbally or unresponsive totally together. And then threats to the airway, make sure like their primary assessment, you make sure that clear the airway out, like any gum or any teeth or blood, vomit, and then control any massive hemorrhaging and then breathing. So we like where I've worked, I've never had much selection other than calling a chopper. But like if you're in a larger area, you can go to the closest appropriate facility. Like if you're in Boston, you'd go to the Shriners for burns, or Mass General for neurological, or whatever else they have down there. So level 1 is heavy, like Dartmouth is a level 1. Portland, I believe, is a level 1 trauma center. And there's like certain criteria these hospitals have to meet. Like I think Portsmouth is a level 3 or level 2 now. So like a level 2 is located in a less populated area, and they have initial definitive care. But I think they're like neurological. There's certain criteria, but like level 3s provides assessment, resuscitation, emergency care, and stabilization. Like a level 4, kind of like I think ABH where our hospital is a level 4. But like UCVH is a critical access hospital, so like they have even less stuff than what ABH does. That's where I used to work out of. And we used to call a chopper a lot more than we do now. Any questions on that? It's basically what we've been over. But I'm sure there's going to be questions about the different facility levels in the near future. AAMS extended period required for access. Oh, I give a definite no idea what this MedVac Foundation International identified criteria for emergency air medical services for patient. So multiple trauma patients, mass casualties. So like an expected period for required access to extricate. So a trapped patient in a cave, which or like a remote patient with trauma. Yeah, there was times that when I was up in Colbrook, the chopper would get there to the patient, like if they're on a snow machine trail, and take off with the patient before we even got there. It was insane, but that doesn't happen in Berlin. Trauma centers are categorized with either adult trauma centers or pediatric. Like Dartmouth has a pediatric hospital, like in Dartmouth. And there's do not transport a pediatric patient to an adult trauma center when there's a pediatric trauma center available. That's kind of common sense. But like if you have an adult, like get the nearest appropriate facility is always like the golden answer. So types of transports: ground EMS by EMTs, A's, and paramedics. But like air units are usually like critical care paramedics, critical care nurses, and like a pilot. But usually the pilot's also like has an EMT license as well. And then actually, like DART has their ground crew that thing. If they can't fly, there's nobody else available. They'll come up if all else fails. So this talks about do we have a lot more slides?
We should. You're pretty much done in the chapter in the book.
Okay, yeah. Then we'll take a 10-minute break. So special considerations: remain calm. Oh, it reminds me of a movie. Remain calm. Like, oh, was it? Yeah, Natural Plume's Animal House. Like everybody's going crazy. And he's like, remain calm. Complete and organized assessment. Correct any life-threatening injuries. Do no harm to the patient. Never hesitate to contact ALS for backup or contact medical control for advice. Any questions, comments? No? Okay. So kinetic energy is calculated by weight and size, weight and speed, mass and weight, or speed and force.
B, I think.
I
B.
think B.
Yeah. It's half the m divided by 2 times variable the
And the
speed
speed is
speed times q.
speed squared.
Speed squared. Yeah. And that'll probably pop up on one of your quizzes too at some point, or maybe even the National Registry. 20-year-old man has a major open facial injuries after his vehicle struck a tree head-on. Which is the following findings within the car that would most likely explain his injury pattern? A deployed hairbag, B, a bent steering wheel. C, non-intact windshields. D, crushed instrument panel. So
B.
I would go with B. Yep.
Wouldn't
C.
it be C?
I was gonna say, I thought it
Because-
was a trick question.
Yeah,
is.
I'm thinking C because they talked about that whole.
If he hit his face on the windshield, yeah.
Yeah. And they talked about the steering wheel being the chest impact
Yeah,
and abdomen. What is it?
it's C. I was trying to figure out why. This typical abrasions of the face, head, arms. Oh, open facial fractures. Yeah, injuries. Never. Yeah, now I understand. This is typical indicates the presence of chest injuries, non-intact windshield. Because yeah, obviously, like starring of the windshield's a good telltale. Yeah, I was involved in a head-on once. Again, we'll leave out the details, but yeah, like I was not seatbelted and my windshield was destroyed, thanks to me. This typically indicates the presence of leg or hand. Yeah, like when they hit the dashboard. Which of the following will most likely result from the third collision and a three collision effect that occurs during a high-speed frontal impact motor vehicle? Extensive damage to the automobile, flail chest and lower extremity fractures, massive external trauma with severe bleeding, aortic rupture or compression injury to the brain. So this is like they said the third collision. Yeah, that's like when the after like the vehicle hit whatever the tree, and then
Right.
your body hits whatever, and then the third part's where the
I
So
would say D.
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 D. Yeah, that's when your organs and the aorta will just tear. A young male experienced a severe blunt trauma in the passenger car, struck another vehicle head on. During your inspection of the interior of his vehicle, you most likely find A, deployed airbags, B, steering wheel deformities, C, starring of the windshield, D, a crushed instrument panel.
Young male, I think that's the key.
B.
Yeah.
Young male, but he's also with his passenger car. I read that wrong.
Don't read
His
into the
passenger.
question.
It's B.
Yeah.
It's all about the chest.
Chest, steering wheel.
A blunt chest trauma, yeah.
Yeah.
B.
D.
And if he's young, he probably doesn't have airbags.
Yeah. Maybe. An unrestrained driver collided with a bridge pillar. Upon inspection of the interior of the vehicle, you note that the lower dashboard is crushed. During your assessment of the patient, you will most likely encounter trauma to the pelvis, yes, a blunt abdominal trauma, severe closed head injury, penetrating thoracic trauma.
A.
I would
A.
say A.
A.
A. I would go with A. Yeah, because that's when it go up and hit the dashboard. Whiplash injuries are most common following: A, rear end, B, rollover, C, frontal, D, lateral.
A.
A.
A, rear
A.
end. Death from a rollover motor vehicle crash is most often secondary to A, crushing injuries, B, airbag-related trauma, B, C, multiple collisions in the interior of the car, D, injection of the patient from the motor vehicle.
I think D.
D.
You
D.
said D.
D.
Yeah, they said D in the slides. That's when they get like thrown like a missile.
I think it could be C.
What's that?
I said I think it could have been C. I think
Mhm.
It could have been, but they talked about it in the slide that was
Yeah,
one of the
no,
big
I get it.
indicator.
you don't always
Morgan, you sound like you're plugging away at a 1980 Apple computer.
Why?
whenever, I don't know if it gets your keyboard, it's just funny sound. It sounds like
Sounds like
The
you're
old-
banging on like
the old school Apple computers.
Oh, it's a stiff keyboard.
All right.
I don't have my laptop. Well, I have it, but I'm not using it. Severe abrasions and injuries can occur when motorcycle riders are slowed after a collision by road drag. Road drag is most often associated with type of motorcycle impact. A, head-on collision. B, angular collision. C, ejection. Or D, controlled crash.
Oh wait. Oh boy.
I think it's C,
I think it's C too.
Yeah, I think it's C.
because they're gonna slide.
Yeah, hopefully.
they're ejected,
C.
yeah.
During ejection, the rider will travel at high speed until stopped by a stationary object. B. When assessing a stab wound, it is important for an EMT to remember that A, stabbings are to an extremity are rarely associated with an exit wound. B, the majority of internal trauma will be near the path of the knife. C, most stabbings are unintentional and cause less severe internal injury. D, more internal damage may be presented with than the external wound suggests.
D.
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 D, yep. Last one. A 40-year-old man was standing near a building when it exploded. He has multiple injuries, including a depressed skull fracture, severe burns, and an impaled object in his abdomen. His head injury was most likely caused by A, primary blast injury, B, secondary, C, tertiary blast injury, and D, quaternary blast injury.
I think it's A.
A.
I think it's B or C.
B.
You think B? But the burns is a C. They talk about that with the tertiary.
Depressed
Yeah,
skull
but it
fracture.
says
That's
his
more
head
like an
injury.
impact.
But the impaled objects, I think, are the secondary.
It's tertiary too. C. Yeah.
Tertiary.
Something
Primary
can go
blast
through the
is caused by
skull.
pressure waves,
skull
including
hitting.
ruptured eardrums and hollow organ rupture. Secondary blast injuries are caused by flying debris, including impaled objects and shrapnel injuries. Tertiary blast injuries occur when the victims are thrown into solid objects, resulting in blunt trauma to virtually any part of their body. Whatever that word is. Quaternary blast injuries include other miscellaneous injuries.
But what's the answer? Because it just said that the second one is injuries are caused by flying debris, included impaled objects. And they had an impaled object in his abdomen.
But they were talking about the head though, right?
They asked about his head injury.
His head
Yeah.
injury
Head
was most
injury.
likely caused by.
Oh, yes. Okay, so it was. All right, so it is C.
Yeah.
Okay, all right. Cool.
All right. So we'll come back at 7:30.
Okay.
Hey Morgan, you want me to do bleeding?
If you want to, sure.
Yeah, I can do that.
Do you have your own slides, or do you want me to pull up these?
No, I've got some. I'll just take control and set up for bleeding.
Okay.
I'm gonna end this recording since it's a new chapter and restart in just a second.